What's up, you guys? It's your boy Miguel giving you your daily dose of radiation. In today's video, we're covering some tips and helpful tricks when shooting a patient in the trauma bed. So to give you context, I'm an Xray Tech night shift. Been doing it for 4 years. I work a lot of overtime, so I dabble in day shift also. So as far as trauma bed, so for those who are new and do not know, a trauma bed is essentially there's a stretcher, and in between it has a gap where there is like a plastic and no metal. So there's a little gap about like yay big at the bottom where you can place your board and you can just shoot straight down. So essentially you don't have to move the patient, you can just shoot straight down. Now of course something like extremities like the feet and stuff, if they're very long or the patient's really low, there is a bar towards the very bottom which will interfere with it. And also for chest x-rays, depending on the level of angle, if they're sitting too high or too low, when you place the board it can slide down. So that's something to keep it. But the chest is like when they're raised up, not when it's like horizontal. So some of the tricks I would give you is for chest x-rays, when you place it, and whoever places the board and the tube have to be in sync, because if the angle is off by a little bit because of the SID between the patient and the actual board, when the board can be perfect, but if your tube is angled or is not correctly placed, it can throw it off and you'll clip it. And majority of the times the one who'll get blamed kind of is the patient. Is the tech who like places the board, that it'll be off. But sometimes you can literally, there's been times where we've just moved the tube and just shot it straight down or more better, and the board placement is good. So that's something that you have to kind of sync. I've noticed that usually everyone kind of places the board differently depending on their perspective or what's going on. I've always noticed when I place a chest x-ray, I always tend to like slide it up like a few centimeters up, because somehow my body miscalculates it, and because usually whoever sets up the tube, the angle of it will always throw it up a little bit, so it's never like perfectly centered, so it's always off. For me, usually with my partner, the way I've always kind of just moved it up a little bit, a few centimeters, just so we don't clip the apices. I ain't really worried about the bottom. We usually always get the bottom. It's always the apices that we always cut off. So that's something to keep in mind. For the other kind of traumas that you could have, let's say someone has a hip. So for the hip, once again, same thing. You just have to make sure, because you're shooting that straight down, you just got to be careful on the placement and make sure that the patient is centered or not close to the rails, because then there's like two metal rails on the side that if the patient like maybe frog hip or do something like that, the board will be the metal will be in the way and you won't get a good picture. You get some artifact. Now, patients being in the trauma room, usually they may come with splinters, they may come with different stuff from the EMS. If they're on the slider board, when you go to x-ray them, it's going to be artifact and it won't look good. So you'll have to get them off the slider board sometimes to get more optimal clear images. I know sometimes you'll have to even shoot them with the slider board to just document, because the risk of injury to their neck outweighs like something you'll be x-raying. So sometimes if you beat them to go to the CAT scan, they'll still be on the slider board just to make it easier. Like I'm talking about not the x-ray slider board, but the one the EMS is used. So it's like usually a thick orange one. So it's something you'll have to work around. And in the trauma bed, usually if the patient's like really bad, you could either shoot the AP or lateral normal, and then you'll have to cross table the other view. Usually, mostly if the patient's not good or is broken, you're only going to be able to get one or two views, unless you kind of angle the tube and kind of get the oblique if you can. Now, being in the trauma room, Like, it can be, you never know what to expect, but usually it's a lot of chest and then patients who are pretty bad and something's broken. So it's always useful to have 2 techs with you. But in a future video, I'll make one when you're just by yourself and you're dealing with like a 2-man job, but it's just you. Alrighty, it's been your boy Miguel. See you on the next one.